Welcome to Healing Together. I'm Nicholas Boileau. Today I'm talking with Dr. Rachel Broudy, who accidentally happened upon elder care as a young physician and made it her life. We talk about the illusionary notion of independence in our old age, the difference between health and well-being, the dignity of risk, the life-giving power of feeling engaged and helpful, and so much more. Rachel brings a perspective of not only a practitioner, but also someone who thinks a lot about how we structure our healthcare systems and services as she advises public and private groups about how to make improvements in our healthcare. I learned a lot about healthcare and elder care from Rachel and really enjoyed her stories. I hope you will too. I'm here with Rachel Broudy. And Rachel, welcome to the podcast.
Thank you, Nicholas. Nice to be here.
Maybe you could introduce yourself and the areas you've been primarily focused on in the more recent past.
I am a physician. I have been practicing in the world of geriatrics for most of my career, although I'm not board certified in geriatrics. I trained in internal medicine at Brigham and Women's and fell into geriatrics the way we often find our paths. Someone said, "Do you want some hours, extra hours?" And I picked up this job in a PACE program. PACE stands for a Program for All-Inclusive Care for Elders, which is a national model of care that is a highly integrative, highly coordinated care model for frail elders and older adults with complex illness. And I loved the work. I loved the model. I loved the focus on quality of life. I loved the interdisciplinary team approach. And it felt like this is what I've been looking for in medicine my whole life, really thinking about what matters to people and how to provide it in a way that is accessible and meaningful to people. PACE has an unusual payment structure as well that allows flexibility and creativity so that you can really deliver what people need in a way that makes their life better. So I loved the model. So I spent most of my career working in PACE programs. And over the course of my career, I started becoming interested in what matters to older adults, particularly as we age. So sort of this idea is that we can't prevent death and decline, but how do we find well-being despite illness, despite chronic disease, despite pain? How do we maintain a focus on meaning and purpose and social connectedness? And how do we balance that against the medical model so that we can still provide good care, but the medical model doesn't drive all the care that's given at the expense of what really matters to people? And so I sort of went on a hunt to begin to see if I could find how to put well-being at the center of our care. There's so many places that this is already happening. So I just want to be clear. I feel like people are doing a fabulous job really paying attention to this. But it's often, because there's a leader or a champion or someone has a particular interest in well-being. But I have been trying to think about what would that look like structurally. And, spoiler alert, I don't have the answers yet.
One of the things you've talked about is the false narrative of independence. Can you talk to me a little bit about adaptation in advance of decline and what that means, that false narrative of independence?
It's a great question, Nicholas. I really, sort of our whole American ideal is based on independence and that we're independent and productive adults, and that's how we find meaning. But I think the truth is, and I think a lot of us know this, is that our lives are actually quite independent. It's most obvious with young children, infants, and with older adults where we are physically dependent for care and certain needs. But, we live in communities, we live in this independent society, and I think we haven't paid enough attention to that as a country, as a nation, and as we build systems to how we do rely on each other. And so part of the narrative of aging is how to maintain this independence forever. And that's just not something that we're going to be able to achieve. And that I'm not sure that we even want to achieve. So I think it's worth just asking the question are we really after independence? Is that what's so important? And if it's not, if it is interdependence, I'd love to be part of a conversation where we start talking about what does that look like? How do we build systems of care that value interdependence as opposed to independence? So that's the first piece. I don't know if you want to take that up before I jump into the adaptation work.
I'm not sure, but you might have said our lives are already quite independent, but did you also mean our lives are already quite interdependent?
I did mean that. Yes, we live quite interdependently, right? I mean, in our families and our communities with friendships, but even things, in terms of economics and the social good and, paying for roads, right? Like we are so dependent on each other already. And I think highlighting this narrative, making it more clear how an attention to this interdependence and investing in this interdependence actually helps us flourish rather than this myopic focus on I'm independent, I'm a rock and I don't need anything or anybody. And then I think once we sort of accept that what we're after is building this fabric of interdependence, then we can do that in ways that are meaningful and robust for each of us individually and for us more largely as a society.
Yeah, I think there's a lot of research in behavioral economics and psychology and psychiatry around the fact that a lot of times the stories we tell ourselves about what we want are actually wrong. You're describing it like, I want to be independent, but I certainly don't want to be alone.
Right. I mean, that is a great point. Like, what are we actually after? And then using the language that describes that. And I do think we've had this, American ideal of independence, pioneering spirit, frontiersmanship, and all of that. And, there's something to that. But I also think that when we think about interdependence and how we rely on each other, there's such richness there. And that's where most of us gain our sense of purpose, our sense of meaning, our sense of connection. And if we attend to that, there's such potential for growth and connection, and also revaluing those things as positive interactions rather than areas of need or just marking our deficit and decline.
Yeah, I often think there's an illusion also around the idea that if I am depending on other people, then I am a burden to them. But a lot of us actually like to be depended on. And there's a reciprocal relationship there that I think nurtures some basic human aspect.
Absolutely. Absolutely. There's so much to say here. Two things. One, I just think this idea of mutuality or reciprocity is so critical. And it's one place where we really fall down in supporting older adults. We think about what are their deficits and what are their needs and how do we take care of them? But we don't often think about how to offer them that kind of reciprocity or engagement or mutuality. How can they give back, even if they have some limited physical or cognitive abilities? But that it's so true. It's so important for us to be in these reciprocal relationships. So I think that's one thing. And then the other is a story. I have a friend of mine who lives in Israel, and he went home to Israel this summer because his mother was dying. And it's one of these complicated stories made more complicated by COVID. But the short version is he got really involved in the daily care of his mother. They got rid of all of the home care aides, and he and his sister devoted themselves to spending time with his mother. And he'd been estranged. He lives in another country. And he talks about this as the most meaningful time of his entire life. That is so the opposite of how we think about that. That wasn't her being a burden on her children. That was this moment for deep growth and personal transformation and reconnection in a way that if he hadn't been able to be available to her in that way to care for her, those things never would have happened.
Was she able to accept that care in a way that was guilt-free and not feeling like she was a burden to her children?
That was a process, which is interesting. Like these things are complex and nothing is simple. But I think that was part of the process, right? The part of the process for this whole family was this rearrangement of roles where she began to accept their help and they allowed themselves to give it, and things shifted and transformed. So it wasn't, perfectly smooth and happy at all times. But I think over a period of time, it allowed for tremendous personal growth for everyone there, and connection and storytelling. And he learned things about his mother that he had never known. His mother was able to hear about his work in ways that he'd never been able to tell her because he just had time to sit by her side and be with her.
That's really wonderful. Can we talk a little bit about safety? I've heard so many stories about people who want to keep the elders in their life, quote unquote, safe. And yet safety is sometimes precisely what keeps you from doing the things that make life worth living.
So safety, I think, is a really sticky and important issue to discuss. Some of the people in the field talk about the dignity of risk.
I love that.
I love it too, because it acknowledges that there is risk, right? And that there is risk in living. And if that person does stand up, they may fall down. And yet there is some dignity in allowing people to take their own risk. But as those risks accumulate in older years, you may have some weakness, some frailty that make you more likely to fall, or you may have some cognitive impairment or brain disease that make you more likely to make decisions that are unsafe, leave a stove on. For family members, we get so attuned to risk and what are the bad things that could happen to mom or dad that we lose sense of what the context is, why those bad things might happen, and what the important is to be able to allow people to have risk. And so when people start talking to me about safety, I think there's a few things to talk about. One is, what's your fear? Like if a family member is talking about safety, what are they really afraid of? Are we actually talking about something else? Are they really afraid of their person dying? Are they afraid of the guilt they're going to feel if they're not there, if something bad happens? But is there something else going on that we can talk about? But also, are there discrete things that can be done? So a lot of people will come in and say, she's not safe to be home alone, which means she needs 24-hour care. And often someone doesn't need 24-hour care. They just need to unplug their stove or to have some help with meal prep or to take up the rug so that they're less likely to fall. And this varies family to family. I took care of one older gentleman who loved to be outside in his garden, and he had some balance issues and was what we call a fall risk. So he fell from standing, which is, quite dangerous. The family, we were able to have this discussion with the family, and the family said for quite some time, we can tolerate these falls. It's so meaningful for him to be outside and to have his hands in the dirt that we are going to, continue to do our best to let this happen. And then at some point that balance changed. He had a terrible fall with an injury, and they ended up restricting his movement so that he couldn't go outside and garden anymore. But they were at least able to engage in this as a spectrum of safety, that there's going to be some risk that's allowed to allow what's meaningful for people, and what's meaningful is going to be different for everybody. The other thing that I'll say about safety is it is important. None of us want our loved ones to get hurt. And there are other things that are also important. So the other way to have this conversation is to frame it as one of several things that matters. So safety matters, but gardening may matter, like to this gentleman, or social connections may matter, or being able to move around and walk, particularly some people with dementia get quite restless. Being able to move may matter. There's no easy answers, but it's important to be involved in this discussion about how to balance these things for the best outcome for each person.
I spent a very short period working in a long-term care facility, and I remember it felt like a storage unit for old people. It was just horribly depressing.
Mm-hmm.
These people may have been safe physically,
mm-hmm.
but it felt completely hopeless and devoid of humanity.
Yeah, that's sort of the worst of what a nursing home can be. I'm sort of slightly cautious right now in these COVID times when nursing homes have been under such scrutiny to feel a little protective, but certainly that's some of what drives my work right now, is trying to improve that experience of older adults in long-term care. But it can certainly be like that you are quote unquote safe, but disconnected from anything that's meaningful, either socially or with whatever your own sense of purpose is. I think there's this idea that nursing homes are safe because there's always a nurse on staff. And there is always a nurse in a nursing home, but that nurse isn't always with your person, making sure that they're safe at every second. One of the things I try and do is remind people that nursing homes aren't necessarily any safer. There are some things that they are better at providing, and there are certainly reasons to be there, but they're not safer than homes.
Absolutely. And I certainly didn't mean to cast any aspersion on nursing homes. There's the work being done there is really amazing and often under tremendous duress, low budgets, very low reimbursement rates, the difficulty of seeing people die and be sick all the time, and what I would think of as essential workers working with our elderly are also some of the least rewarded workers in our culture. So it's a tough problem. And we could do a whole other episode on that. But I'd like to switch gears and talk a little about well-being, which is really central to some of the work you've done and continue to do. In fact, it might well affect everyone in the elder care ecosystem, including the underappreciated essential workers I was just mentioning.
I've been on this search for some structure to keep well-being at the center of our models of care for older adults. And so in this search, I found this really interesting organization called the Full Frame Initiative that has a model of well-being. And their model of well-being is really interesting for a number of reasons. They talk about these 5 domains, which are social connectedness, safety, stability, which is sort of like routine, and also the fact that if you change one thing in your life, the whole thing isn't going to come crashing down. So some amount of predictability, meaningful access to relevant resources, so that not just that you have food, but you can access that food in a way that is meaningful to you without shame and harm, and social connectedness. I think that's all 5. Part of what's really interesting about this is not like a mountain that you climb and you get to the top and you've gotten them all. It's sort of like, this is a model that works for all of us. You know, me as a physician in the nursing home, as well as the older adults that I'm taking care of. Like, this is how we all make decisions about everything in our day, is balancing our needs in these 5 domains. And that we're always going to have sort of challenges and conflicts among these 5 groups, but we're always sort of trying to kind of optimize the apples in each bucket, so to speak. And then the other thing that's interesting about this is, you know, there's a social analysis embedded here, a social justice analysis that says, you know, people are going to start this game, life game, with different amounts of apples in each bucket. So, you know, I have a fair amount of apples in all my buckets. I'm white, I'm well educated, you know, my family is a long history of middle to upper classness. So I'm in a really good starting point. And so my ability to address my own safety, social connectedness, I have a lot of resources to do that. But people who have fewer apples in those buckets are going to respond differently. There's going to be more of a sense of crisis and tension around meeting those needs. And it really helps, I think, understand how people make choices that don't seem to make as much sense from the outside. So it's a really interesting idea for me in terms of thinking about how we all attain our well-being. And while health is very important, and certainly what I'm trained to do in the medical field, it's a very small piece of the picture in terms of what matters and what creates our own well-being.
And you're making a distinction between health and well-being, which I really appreciate. Can you talk a little bit more about that?
Yeah, absolutely. I love this idea of well-being because I work with people who aren't healthy. And, you know, I work with people who are going to die and they're going to get more sick and their pain is going to get worse. And that's what we're all facing, you know, to some extent. And I think I'm driven by my own, you know, internal fear. I worked with an attending once, and when I was in medical school, who said, you should study the thing that you hate the most or that you're most afraid of, because that's what's going to motivate you the most. And as it turns out, you know, that's sort of true. And what motivates me is, how do I continue to live a meaningful life as I lose abilities, which is going to happen. You know, that's the natural course of things. And so I think the first step is acknowledging that, again, it's fighting this narrative of independence and sort of quote unquote successful aging. Like, you know, 80 is the new 50. Well, that's great as long as you're the new 50. But what happens when you do begin to decline? So, you know, what I'm talking about is really more towards the end of life. It's not people who are already aging well and healthy and active. It's more what happens when we do lose those abilities and we're not healthy. Can we still have well-being? And I believe we can, but I also believe that we've relegated the care to attending to health, but haven't really focused on the rest of it, the well-being and the purpose and the connection and the meaning, despite illness, despite frailty.
You use the word purpose, which I also really appreciate. And I feel one of the biggest themes as we get older is the inability to serve a purpose, to be useful to others. I think that's like a primary drive to what I would think of as my own life force is when I'm feeling useful, I'm feeling good and I'm feeling less involved with my own complaints and my own problems when I'm focused on helping other people. You and I have talked about Peltonly, where we're trying to connect people, patients and caregivers to each other to be supportive to each other. But one of our ideas is that for the provider of advice or support, this is really rewarding. Is there a way that you've seen that we can give jobs to people who are either in nursing homes or at home, but with very limited capability? Maybe examples of that could help other people.
Well, my favorite example is one I just heard about from a medical anthropologist named Anna Corwin, who studies Catholic nuns. And she works with this term, meaningful decline. So, we are going to decline. We might as well try and make it meaningful. But she talks about working in this monastery where nuns come back to the mother house when they're too frail to be out doing their work in the community. And she tells the story of this one nun who was really approaching the end of her life and was bedbound and would lay in bed and moan. That was pretty much all she could do. And one of the sisters walked in to this woman's room and said, "Sister Eileen, I'm really suffering. I need a blessing. Can you give me a blessing?" And the woman continued her moaning. The other woman just stood there for a while and listened. And then at some pause or break, the woman said, "Thank you for your blessing. I feel more connected to God or deeply touched," or, whatever she had said. And it was just like, it blew me away. It was the story of this woman who was able to have this woman, Sister Eileen, participate in this meaningful way, in a way that I never would have been able to imagine. Right. And it's almost like improv skills in a certain way, like this ability to think creatively about how we imagine other people helping each other. But I think that that's really true. And it's something that we overlook all the time, and again, some of my work currently is with Ariadne Labs. And we're looking specifically at this nursing home conundrum and how to change this, both to sort of decrease the infection rates in light of coronavirus, but also how to get at this nut of how to reintroduce meaning and purpose and connection. But part of what our medical model does is segregate the nursing home community into old people who need care and staff members who provide care. But there's no sense of community or people being able to give back or to give to each other. And so this is one of the things that we're exploring is, how do you do this peer work with older adults? Are there ways that they can support each other? Are there ways that you can use one person who's there to help one of the other people who's there and solve some of these problems? I mean, I think this is a really unexplored area because it's sort of taboo in the medical world about asking one patient to help another. Where you have seen it a lot, I think, is in the recovery community. There's a ton of peer work and peer support and peer modeling around healing. And the two themes there are the people who've lived through it know how to get through it the best. But also, like you say, that giving back and that being needed is part of the healing.
And when you say recovery community, you mean recovery from addiction?
Yeah. They've done a ton of work in the peer recovery model, which is really, it's quite beautiful work.
I've heard of some of those stories. And, just to go back to that, the idea of reciprocity, and you mentioned, this medical care model where there's a caregiver and a care receiver. So already there's not a lot of reciprocity between the staff and the patient, I imagine, in most places. Is there something you've seen, like if I have an elder in a nursing home in my life, have you seen great examples of little ways in which it can become more of a reciprocal relationship?
I think this happens all the time, but we don't highlight them, we don't value them necessarily, and we don't build our care around them. So one of the things that's come out in COVID is all these incredible stories of CNAs, the certified nursing assistants, doing this work all the time. So showing older adults how to use their cell phones or using their own cell phones to connect to their families, reaching out to communities, trying to do things in the nursing home that make them feel connected because they've lost that ability to visit with their family during this crisis. We've been interviewing CNAs, and there was one story about a woman who was an older adult resident who was very distressed, but who was a knitter. And she couldn't really knit anymore, but she still sort of inhabited the identity of being a knitter. And so the CNA actually took off her sweater and pulled a thread to create this huge hole in the sweater and went back to the woman and said, "I ripped my sweater. Can you fix it for me?" And so the woman, the older adult, sat there sort of trying to re-knit the sweater for this woman, for her aide who had done this to create work. And it's just an incredible story to me of someone trying to find meaningful ways to engage the person. It wasn't really about fixing the sweater. It was about making that person feel needed. The other work that I think is really interesting here is there was a guy, Dan Butner, who did this project called the Blue Zones, which has become quite popularized and I think has lost some of its power in the popularization. But when it initially came out, he looked at places all around the world where they had higher rates of people living to their hundreds. And what you saw is that people had a role and an identity, even as that role and identity sort of shrunk and got smaller, sort of consistent with their abilities, they belonged somewhere. And so I'm remembering this picture of this family in the hills of Sardinia in Italy with the patriarch at the head of the table. He's like 103 years old. He's tiny. This whole family is out there sitting at this table. There's probably 25 people there of all ages. He's at the head of the table. Who knows if he understands one thing that's being said? Who knows if he can hear anything? And he may well have spaghetti sauce all down the front of his clothes, right? But he belongs, and he is still sitting at the head of the table. That's what gets lost in the nursing home, is that sense of belonging and role and identity. And this gets back to what you were saying at the beginning, is this question of adaptation. Is when people are living in their own homes and in their own communities, there's some ability, although still limited, to adapt their new worlds and their new level of ability to the world around them. But when they're moved into a nursing home, a lot of that is taken away. So one of the questions is, can we recreate that in nursing homes in different ways for people?
Yeah, and certainly at home, I'm hearing loud and clear, let mom cook, or let dad help you build the shed outside if he possibly can, instead of saying, no, I got it. You just sit down in front of the TV and enjoy yourself.
It's so great that you mentioned that. Like, take a lesson, Rachel, because it's really hard to do, right? So my mother-in-law asks all the time if she can help while I'm cooking and cleaning. And the fact is, like, she can't actually help in the way that we think about help. She has dementia and she's not able to really wash dishes or chop onions. But there are things that I could think of that would be useful ways for her to engage. I could put a bunch of vegetables in a pot of water and have her wash them. I could ask her to fold napkins. And I so often don't, because it's time consuming and I'm rushing and I'm trying to get dinner on the table. But that's exactly it. Is this takes time. It takes a little bit of planning, but it's perfectly doable. And it means changing what our idea of help is, right? It's more about engagement than help. There's a researcher at Harvard, Nancy Ellen Langer. She did this one great study where in a nursing home with dementia patients was around autonomy and mastery and putting people in charge of a plant. So 2 different groups of people, everybody got a plant. One group said, oh, the aides will take care of your plant. Isn't it lovely? You can look at it. The other one, they said, you need to take care of this plant. You need to water it. You need to feed it. You need to put it where you want it to grow. This is your responsibility. And the people who had the responsibility for their own plant lived longer, had better medication adherence, and more engagement in the activities of the nursing home. And again, it's all really about our culpability in the system, that the way that we are seeing people and defining their roles as passive versus active inhabitors of their own selves creates their reality. Really interesting work.
Incredible work. And so in line with some of what we've talked about, where having a purpose makes all the difference.
All the difference.
One of the things I worry about when I hear about new models of care is adding to the complexity of care, which already seems so complex right now. I'm curious to know how you see it as a physician, because as someone who even has to go through the horrible process of figuring out which insurance is right for me and my family, and then getting the volumes of information from the insurance companies saying, here's what's covered and here's not what's not covered, but it seems to take 150 pages to tell me that. What is it like as a physician? And I understand we're in a completely different game right now with COVID-19. So of course, speak to that if you want to, but that's just an extra layer on top of an already very difficult system. Is it as hard for physicians?
I think it is. I think this is a critical question for our day. Everybody complains about this, patients, doctors, nurses, medical assistants, hospital administrators. It's not working for anybody except possibly the insurance companies. Or it's working in this incredibly marginal way where we get what we need, but in a way that's incredibly time consuming and certainly not clear. I think we need a single payer health system. I will say that.
Rachel, can you just say what that means for people, what single payer health system means? Because I think sometimes people are even confused about that term.
Well, I'm not sure that I, have the best or clearest or most knowledgeable answer there. But I think, just like you say, you don't know who's paying for it or what's being paid, or one insurance covers one thing, but not the other thing. Having one set of rules, one place that it's covered by, and having that be clear makes a lot of sense. I will say that my experience in PACE was a pretty blissful experience. PACE is paid in a different kind of way. So you're paid per member per month. So you get a chunk of money for every member in the program, sort of based on how at risk the system thinks, Medicare thinks they are, sort of some combination of their health and illness factors. And then you get to spend that money however you want, right? And the idea is that people need more flexibility in spending money so that it can't be just fee for service. And so I think there's lots of answers to your question about single payer. One of them is having one place that it's all coordinated under, and so that everybody has care, right? Everyone needs to have health insurance, and that is not the state in this country. I think I just read something like 30 million people in this country are not covered by health insurance. Don Berwick wrote that in an article last week, which is a lot of people. We should be ashamed of ourselves. And, there's different ways of financing it. So fee for service is you're paid for an office visit, you're paid for a procedure, you're paid for a hospital stay, and that builds certain kinds of incentives into the system. But what we really want is care that keeps us well and healthy so that we don't need all those procedures and medications and hospital stays. But we're not set up to provide that kind of care.
Right. And what you're saying is in fee for service, the medical professionals we rely on most don't get paid if we're well.
Exactly.
And that doesn't make a whole lot of sense.
Exactly. Or in the context of all the work around the discussions around social determinants of health and racial inequalities right now, we don't get paid to address those things either.
Right. You only get paid when you perform a procedure or an office visit.
So some of that is changing, and that's very hopeful and excited. And COVID has accelerated some of that, that the health system has had to respond very quickly. And I think it's motivated a lot of changes, which are exciting to see what's going to happen.
As a physician, are you living the life you dreamed of when you went to medical school and were, bushy-tailed and wide-eyed, excited about curing people and helping people?
I have to say that in the PACE model of care, it was pretty close. I really felt like that model got closest to anything that I'd seen. I feel like for me, that's my gold standard of what a care model should look like for people who have significant illness. Not everybody needs that much care, but for people who are frail or have complex chronic disease, that felt pretty blissful. But even then, I still felt like it's at risk of becoming hyper-medicalized in a way that's not helpful to patients and to families, unless there's something else very explicitly at the center of care, holding it to well-being. I'm currently also a hospice medical director for a small hospice program. And, one of the things that astounds me is, speaking to this complexity, is that people need to enroll and disenroll in hospice in order to get the right care. So there's no way, it's in such contradistinction to the PACE model. There's no way to just provide people what's clinically indicated, even within a strict medical model, to say like, oh, well, you probably need some palliative radiation and you need this medication and you need, this much home care. And we will continue to, change all of these interventions as your clinical condition changes. It's sort of like you either have hospice and we're pulling back on all these other things, or you don't have hospice yet and we can't provide you with the kind of support that hospice can provide you. So the system prevents providing the kind of care which people need, which is a much more flexible, individualized system, right? So people disenroll from hospice when they get better, or they get hospice care and they start flourishing because they finally have the support they need. But then they flourish, and so they're no longer eligible from hospice, and so you have to remove the hospice supports.
And the definition of hospice is really end-of-life care.
Yes. To enter into a hospice program, you have to have 2 doctors say that you have a prognosis of less than 6 months. Doctors can be wrong about that, but it is sort of end of life, and the idea is you're not pursuing curative treatment anymore, only palliative or comfort care, but not curative treatment anymore. And most people are in hospice for a very short time, not anywhere near that 6 months, but weeks.
Weeks, and then usually a rapid decline.
Right.
But occasionally a recovery or a flourishing, as you said, and then they have to get out of hospice and then go back in at some future point.
Exactly.
Let me ask you, as you think about your future, you're exposed to people who are dealing with end-of-life issues all the time. What provisions do you make in order to ensure that you don't meet with the less favorable experiences you've witnessed as a palliative care doctor?
That's a great question. I think one of the things that I have learned over the time of my career that I try and rest in is knowing that things change and they're always changing, and then just trying to be aware of that. And so having that be part of my reality, so that it's incredibly important to talk about advanced care directives, and for me to be talking about them now, and for me to be talking about my parents with theirs, and also that conversation has to continue as things change, because this is not something that happens at one point in time, but it shifts. And, the other thing I think about is I hear so many people, just had this conversation, with my husband this morning, actually. He was saying, oh, my mother would hate it if she saw where she was now. And I said, but she is where she is now and she doesn't hate it. Like, that was a different person then. This is a different person now. And who we're seeing now is actually okay with her life as it is. And sort of, this is part of the acknowledging decline and then trying to adapt to that in meaningful ways. So I think being aware of that change and letting ourselves adjust to that, and sort of freeing, particularly as children of older adults, freeing ourselves from, well, mom always said she never wanted to be in a nursing home. I am not someone who loves to send people to nursing homes. And yet I've had people who said, I'm going to be taken out of this house in a pine box. This one woman who was fiercely independent. And when she finally needed a nursing home, she did okay there. She wasn't miserable, despite all of my expectations that she would be. And so I think there's something about that. And then again, coming back to the question you asked at the beginning about adaptation, I just remember a story by Louise Aronson, who's a geriatrician out in San Francisco, who tells a story about her mother. If I could be like this, I would do this. I don't know that I'm this well prepared, but her mother is preparing for her own decline. So her mother says, I think she also lives out in San Francisco, but I could be wrong. Like, okay, I know one day I'm not going to be able to drive. And if I, wait until the moment when my license is taken away, it'll be too late for me to figure out what to do. So I'm going to start practicing now. So her mother practices taking the buses, figuring out the bus routes, using one of those grocery carts, that you can see in the city that you push around and get help getting on and off the bus with it. But she is preparing for the changes to come, so that when those changes do come, the adaptation, she will have already prepared herself for that adaptation. So she'll have kind of the skills in place that she needs to adapt. we can't all have that much forethought, but I think there is something about we need to be expecting the decline that's coming and stop being deniers of this decline. And then once we face it, then we can say, well, how do we do it meaningfully? How do we do it well? How do we do it in connection with family and friends that maintains meaning?
Expecting it and accepting it is what I think you're saying. And I think you're also saying we need to stop looking at ourselves and at each other today with yesterday's lenses.
Yes. Great way of rephrasing that. Absolutely.
I hear it all the time too. This person would hate to see where they are now, or they probably hate where they are, but you're right. Often they're just living their life. And we put those lenses on and just stick a layer of burden onto that moment or that interaction, expecting someone to be who they're no longer, or expecting ourselves to have an experience that we can no longer have.
Exactly. I mean, we look at that and we fear the loss that's to come, right? We love this life. We love our ability to do all the things that we do, cook, go running, participate in our work and our family, whatever it is, right? We don't want to lose those things. But where there's a failure of imagination is understanding what living fully means when we have less ability. Being clearer about that sense of meaning and purpose and connection can only help us. The disability rights movement has done a ton of work around this, shifting from a medical model to a social model, but also saying like, hey, my life is really valuable. Don't look at me and say that this isn't a life worth living. What I want you to look at and say like, wow, look at all the ways that they found to engage, Again, these personal stories. My husband, he will sit on a chair and look out at the ocean, and he'll be happier probably then than he is now with like having to do all the chores around the house and stuff like that, right? Like it's not a lot that he's going to need to create happiness, connection, and fulfillment. So how do we imagine what that is for people and for ourselves and inhabit that so that we can continue to engage with them as full beings?
Yeah. And so we can continue to engage in our own life, not as a diminished thing, but really as what it is right now.
Right.
Do you have time for a few rapid fire questions before we wrap up?
Absolutely.
Okay. So 2 or 3 of your top criteria for well-being.
I read something recently, and I don't have the man's name who did it, so I can't give you the citation, but he has 3 things, which this is my most recent favorite thing around well-being. Having, loving, and being. It doesn't get simpler than that, right? Having the things that we need, food, shelter, and clothing. Loving, being connected in ways that are meaningful to us. And being, what are the things that we are doing that's providing us with meaning and purpose?
That's beautiful. I just read a quote from Jack Kornfield, and I can't remember his first 2 things, but the last one was getting as good as possible at letting go. I thought that was fantastic.
Yeah.
In your mind, what's the top difference between wellness and health?
I think wellness and health are similar. Health is a little bit more of an objective criteria. Wellness is more of a subjective feeling, but I feel like wellness is still dependent on health, which is partially why the word well-being interests me, because it feels like it's not dependent on health. That you can have chronic disease, you can have chronic illness, you can have frailty and debility and cognitive impairment and still have well-being.
You've seen a lot of people go through some pretty nasty physical, probably emotional experiences. What would be your top self-care tips, having seen so many people? If you were to give us maybe 3 top ones that might not only work for yourself, but also for people who might be less mobile or not involved in a career right now, or just trying to take care of themselves through their older years.
Well, they're not particularly insightful. I think they're all the things that we know. So one is being active. So using your body in any way that you can is really important. Being connected, getting out of your own story, kind of like you were saying. So whether that's, a social visit, whether that's helping somebody else, being of service, I think is immensely valuable in any way that you can, even if it's just checking in on your neighbors, whether those be neighbors in a nursing home or your street neighbors. And then the third, which is something that I aspire to but have not yet attained, which you hinted at a little bit, but I think a meditation practice is incredibly valuable. I mean, it's really helpful for, as you've mentioned, this idea of letting go of these things that we can't control. It's really valuable for a gratitude practice, appreciating what we do have in the moment. You know, in some of these trying times of COVID, when I was struggling, my husband said to me, you know, right now, he said, yes, I know that's all true, but right now, this moment, this very moment we're in is okay. And I can't tell you how many times I've come back to that in the last few months of just saying, pulling it all back in and saying, right, but right now it's okay, which is not denying everything else that's happening on the outside, but sort of helping ease some of that panic and overwhelm that can often disable us.
So much of what causes us suffering in this moment is our thoughts about what's not happening right now and right here. All the stuff that's happening tomorrow or yesterday or elsewhere is crowding into what we're experiencing right now and making it much, much more painful to live through.
Yeah, absolutely.
Well, I've kept you from your purpose long enough. But I'm so grateful. I'm so pleased to be able to do this.
All right. Thank you.
Thank you.
Be well.
You too.
Really a pleasure.
Bye-bye.
All right. Bye-bye.
Healing Together is produced by Healthenly. Our theme song is Ramble, composed and performed by Ed Morneau.